We are very excited to welcome our guest, Sebastian Tello Trillo. Sebastian is a recently promoted Associate Professor of Public Policy and Economics at the Frank Batten School of Leadership and Public Policy at the University of Virginia. He is also a Research Associate at the National Bureau of Economic Research. His research encompasses various topics, including health insurance, mental health, Medicaid, health behaviors, and HIV, with a focus on health policy in the US and Latin America. He was also a 2019 to 2020 Scholar in Residence with the Institute of Research on Poverty. Alongside Alex Hollingsworth, he co-hosts the podcast, The Hidden Curriculum, which discusses various issues and conducts interviews to elucidate some of the hidden aspects within public policy and economics professions. And finally, he actively contributes to Econ Taki, an organization dedicated to reducing barriers for aspiring PhD candidates in economics by offering resources and classes. So please join me in welcoming Dr. Tello Trillo.
All right. Just making sure that I'm speaking to the microphone here. Thanks, everyone, and thank you for coming to this lovely lunch. It's been a pleasure. It's a beautiful day today, too. And thanks for the invitation. So I'm an economist by training, so a lot of the stuff that you'll see will have that taste, but I've assembled a talk today on losing public health insurance and its implications. And my motivation of assembling this talk is kind of talking a little bit more broadly about a set of papers that I contributed on and the papers that also I've not contributed on, but touching this literature to see kind of like what we've learned from this topic and what is still the stuff that we don't know and maybe some kind of like lessons. So I'm happy to receive any questions or clarifications while I'm talking, but hopefully we'll have some time at the end. We want to have a longer discussion. All right. So as I said today, we're going to discuss this topic of losing public health insurance and kind of focusing on this like four main practical questions, which is why is this topic important? Why does it matter? What do we know about this topic? So what have we actually learned? What do we not know? What are still the pieces, missing puzzle pieces? And finally, what are we learning from these exercises that are actually used for policy or thinking about policy design? So like at the end of the day, what is something that we can actionably take out of this? So my hope is that to try to answer these questions to the best of the ability, but I'm sure there's a lot of holes in them. So why this topic is important, I kind of see it as two different angles of where the importance comes from. So one is kind of like the academic, intellectual type of importance, and then the other one is like the policy relevance importance. So I think from the academic point of view, from that intellectual contribution, I think this exercise of understanding what happens when people lose health insurance, it really helps us reflect on the value of health insurance, like what is it that the people are actually losing, and why is that important for them, and how do people cope without health insurance? And I think that's been one important point. And then the second important point is that a lot of what we know about the relationship between health insurance with other outcomes or the value of health insurance really comes from a lot of exercise in which people are gaining health insurance. So people have studied Medicaid expansions, people have studied this randomized Oregon health insurance experiment or the Massachusetts reform in 2006. A lot of this is like about people gaining insurance, and we really haven't studied until this literature came about what happens when people lose health insurance. The second angle is really about policy. So it helps us understand what happens when people are stop eligible for programs like Medicaid. And understanding how they cope with this is part of like I think the interesting policy angle, and also unfortunately or realistically, this is something that like happens often not just in the United States but around the world, where there's a budget deficit, there's a budget constraint, there's like not enough money, or there's political discussions about that, and people want to contract social programs, and this is a consequence of that. And so I think knowing what happens and what are those consequences of contracting the social programs is the interesting policy angle. So one thing that we may be curious about is like, as I motivated this, is why is losing different from gaining health insurance in some way? So intuitively, you may think that it could be very similar, right? So in some ways, if I lose health insurance, right, I'm losing that financial risk protection that insurance gives me. And when I gain it, I gain that. So that should feels really similar. But there is actually things that maybe are not as similar. So for example, we can think about what individuals lose versus what they don't lose. So obviously they lose that financial protection, maybe access, right? Okay, if I don't have insurance, maybe I'm not gonna go to the doctor as much, right? And that's kind of like losing access. But things that individuals don't lose are things that they've like gained throughout the system. So I think at the core, the difference between gaining and losing health insurance is that the starting points of those individuals are actually very different, right? A person that loses health insurance, the factor, their initial condition is that they had health insurance, right? And that is very different from gaining health insurance where your initial condition is you were uninsured. And so those create like some different status quos about the individual. So just to put like a clear example, if you lose health insurance, you lose these things to like all this access part of things. But for example, you don't lose your health information. So say you've been with health insurance for a while and you're a person on Medicaid, and throughout that process, you discovered you have a chronic condition like diabetes or hypertension and so on. So through that process, you're gonna learn maybe what medications to take, how to manage your condition, what nutrition to have, and so on. When you lose health insurance, you're not losing any of that. Like all that information and knowledge that you gather about understanding your condition and also how to navigate a system, knowing what specialists are important, what visits are important or not, it's still there with you, right? And you don't actually lose it. You may lose access to, financially affording them, for example, but you don't lose access to that information. And that's something that doesn't really happen when you're gaining, because when you're gaining it, you're like, maybe don't know anything about it, and then you start learning all that stuff once you start going to the doctor a lot. So that can create a lot of differences between gaining and losing health insurance. And again, this comes in a nice contrast because a lot of what we know about this health insurance and any of these outcomes, health and financial, comes from these experiments where people are gaining insurance. Okay, so we discussed why is it important and why we need to study from both angles. Let's figure out what do we know about this topic. So before going into what do we know, I want to do a little bit of recap on how do we know what do we know, because I think it will be important to contextualize. So if we wanted to know what happens when people lose health insurance, there is maybe hopefully a couple of things that intuitively come to your mind. So the first thing that we can do is why don't we just compare people who don't have insurance to people who have insurance and see the differences, right? And then we can kind of infer, okay, if you lose it, you would look like an uninsured person. And we can do this comparison. And here I've done something hopefully really simple, which is I grabbed this national health survey called the National Health Interview Survey, NHIS. And in there, individuals report to assess their health, self-reported health between 1 and 5, Y being poor, 5 being excellent, right? And these are averages of those measures by insurance types. So it says that like uninsured individuals, on average, they rate their health like about 4.25, right? And what I've done here is the only magician thing that I've done, which is not really that magician thing, is I've netted of sex and age effects because I don't want to compare, let's say, uninsured to Medicare, knowing that Medicare is older population. So I try to like net to the best that I can, like some age effects. Anyway, so let's look at this and let's compare, let's say, uninsured to private. And what we would find is that people who are in private health insurance are reporting like better health, right? If people who are uninsured, maybe that's not that surprising. You can think that's because of insurance itself. Then let's compare uninsured to Medicaid. And actually, the Medicaid bar is lower than the uninsured. And so that would lead you to conclude that people who are in Medicaid have worse health than people who are uninsured, and essentially you can even think about making the argument of like, okay, Medicaid really doesn't work because it's actually hurting people's health, right? In some way, if you were to see it like that. You can do the similar comparison with Medicare, and we can do the comparisons without insurance. So this is a comparison we can do to understand that losing public health insurance. But the challenge is like, well, this comparisons may not be apples to apples, right? Because, for example, there may be the people who are uninsured are choosing to be uninsured in some way and maybe are not even eligible for Medicaid. And so we're comparing maybe like very low income individuals to higher income individuals. And of course that they're gonna do better with their health. So making this comparison has a lot of confounding things that doesn't make it as clean. All right, so that's not a great option. The other thing we can compare is, well, why don't we compare people who lose health insurance because they lost their job? So about 60% of us get private insurance through our employer, and that's how most people in the United States get their insurance. So one thing we can do is like, well, if you leave your job or you get fired, then you're losing health insurance, and we can see the effects of that. So that makes sense. The problem being that, well, you're not only losing health insurance, you're also losing a job, and your income is changing, right? And so that comes with a lot of other things, and so we don't want to confound those things. So that may not be a great exercise. Another one that we can think is crossing eligibility limits. So in the United States, for example, we have this mandate that says that individuals can stay in your parents' health insurance into your 26, I believe. And once you turn 27, you can't. And so you can think about comparing people who are 26 versus people who are 27 and lost health insurance because they get kicked out of their parents' plan. Or we could also think about playing with the income thresholds. So if you think Medicaid has an income threshold at eligibility, we can compare people who are right below and right above the threshold. There's somewhat similar, and so we can see what happens when they lose health insurance. And this is a good idea, and we can use this. And so I leave that as a placeholder there. And then finally, the other point is maybe using policy reforms that have existed throughout history to study what happens when people lose health insurance. And by policy reforms, I mean reforms in which a state, a nation, you name it, had a budget deficit, and they're like, we need to contract our social programs, we need to make things smaller, we're gonna kick people out, long story short. And then we can see like, hey, what happens when you kick those people out of health insurance? And we like this because it's a little bit of what we like to call exogenous, meaning like, I didn't choose to be kicked out, somebody else chose to be kicked out for me, and so there's nothing that you could have done, or there's not a lot of choice on that. This has happened in many countries, in Spain, in Greece, in the United States, happened in several states. So what we're gonna do today is we're gonna focus about the lessons that we learned from kind of like that fourth group. And we're gonna see a little bit at the end of what we learned from like the group number 3. But really there's the bulk of the work, it will be in like those policy reforms. So since I'm gonna focus on the US context, I wanna talk a little bit about that US context and kind of narrow down on how do we know what policy reforms we're using. So in the US, just very broadly, public health insurance is provided by 2 programs. This is Medicaid and Medicare. Medicare is public health insurance or subsidized health insurance, if you want to see it that way, for people who are 65 and plus. So usually related to people of that age. While Medicaid covers for specific categories of individuals combined with specific incomes. So this is like kind of like what we think usually people think like Medicaid is for individuals with low income. That's a little bit of, I think sometimes like misleading, because there are still people in the United States who may have like essentially 0 income and not be eligible for Medicaid. And so it's not really just the poor, it's like the poor, a subset of the poor, right? So in places where if you're a childless adult, you have 0 income, you're not gonna qualify for Medicaid no matter what your income is, right? So it has like categorical who you are and income at the same time. There's also some subsidies that we provide in the private market, and if you wanna see that as a way to provide public health or health insurance, you can also see it like that. So what we're gonna do today is we're gonna focus on a lot of studies that I had the opportunity to work on that look at one of the biggest disenrollments that we've had in the United States, which is the TennCare reform. It's not, so it used to be the biggest, but it's not the biggest anymore if you count the public health emergency disenrollment that just happened this past year, where a bunch of people were essentially, well, they remained in Medicaid, regardless of their eligibility changing until that mandate was over and then people were disenrolled. TennCare is the Medicaid program for the state of Tennessee. And so we'll dive into that. All right, so let me tell you what happened in Tennessee, just give you some context of that, and then we'll dive into how do we study it. So Tennessee is a very interesting case for health insurance and public health insurance. Before in '94, they had traditional Medicaid, and this is just following federal guidelines of who needs to be covered and into what income. And it was funded through mostly a special tax on providers and hospitals that they had. Now, there was an agreement that this tax would expire in '94, and then they'll reassess things. Yeah? So this was going to happen, right? People knew this was going to happen, and the governor at the time, he was a Democrat. I think the government hired a consulting company, I think it was McKinsey or something like that, to do a report of like, what can we do to keep things going? And essentially, they had reports said three options. Well, you can increase taxes, right? Which is kind of like change the source of revenue. You can also pay people less, reduce provider reimbursement rates. So like let's pay, less reimbursements for hospitals, for doctor providers, for social workers, et cetera. Or let's completely redo how we do like restructure and help finance the state of Tennessee Medicare program. So like completely change things, right? The context that I think it's important to know for some of us who remember or don't remember is that in the '94, there was a big push nationally to think about universal coverage. And actually, the Clinton administration submitted a bill, right, to see if we can get this something similar to universal coverage between that and the ACA. And so there was a lot of like impetus and ambition to do like major restructural changes. And Governor McWhorter was a Democrat, and so I think was part of that wave and decided to take the third option, which is like let's completely redo or rethink how we do Medicaid in Tennessee and push for that. So it was, I think, I don't know if this is the only state, but it might be the only state that like really pushed for a big reform during this time of like appetite for reform. And so his main two goals were the following: cost control, right? So we got to make sure that we keep costs low in some way. And the big idea for that was to change everything to managed care organizations, which were a big new idea back then. And so the simple idea is instead of us, the government, paying provider reimbursement rates for each claim that people have, let's have this other company come in and they handle all of that, and we're just gonna pay you a per capita payment for each person, right? So let's say I pay you $100 for each person, and you deal with it, and you figure out how to make profits out of that. So in some ways, what's nice about this from the state's point of view is that you know what the costs are going to be, like broadly so. Obviously, there's agreements between the managed care organizations can ask for more or less depending on the individual and et cetera. There's a lot of details on that, but that is a way for the state to be like, this is how much we're gonna spend and so on. And then the idea was that with all that extra money that they would have, because they would have extra money, but the cost controls, that they would expand public health insurance eligibility. And so they would up the income levels to about 400 of the FPL, which is pretty generous for this time and for this state, and even now, I would say. And more importantly, expand eligibility for childless adults, which is something that is basically had never been done in the United States before in that time, right? So those were pretty major changes that they were proposing in the state of Tennessee. So they said, okay, let's do it, and let's call it the TennCare program, and they did it, okay? And it was a big, so if we measure success by like how many people enrolled, it was a big success. A lot of people enrolled in this program in the first few months, in the first few years, even more. So in that sense, if there was a need, it was met for sure. For a couple of years later, and by the early 2000s, the state government would start running into budget deficits, right? Every year they were hitting deficit, it was getting bigger. And again, they do what states do, and they ask a consultant firm or whatever to produce a report on like, why are we in debt? And they say, yes, you are in debt, and we think it's the Medicare program that is accruing a lot of cost, and this is growing, and it's gonna keep growing, and this is a big issue. So you need to address that. So between this is like early 2000s to this was in line with, again, political context matters, with election season for governor in Tennessee. And so the big conversation piece was healthcare. How do we cost control the Medicare program that has gone off budget? Little side note, it's a little bit unclear if Medicaid was really the big issue there with the state budgets, but it became the quote unquote evil character of the narrative. And so like, that's what people dealt with. So the person who ran for governor and won was Governor Bretson, and he was a Republican, and he came from the healthcare management world. And so he had a very powerful narrative about, I know how to do business in healthcare, I know how to cost control, I know how to do these things to fix TennCare, okay? So he got elected based on that platform, and his big idea was to cut coverage for people, right? And so to be fair to Governor Bretson, there's only a few things you can do if you're trying to cost control, right? You can pay people less, you can offer less benefits, or you can offer the same benefits to everyone, but to less people, right? There's only like very tangible few things you can do if you're trying to cost control, as opposed to like raise revenue, higher taxes and stuff like that. And so at the end of the day, they looked at a bunch of proposals and decided we have to cut back on the number of people. Initially they were trying to cut the benefits. That didn't work very well for different reasons. And so they were like, let's just concentrate on having less people be enrolled in Medicaid by terminating eligibilities. And so in January 2005, it was announced that Medicaid for Tennessee was going to terminate eligibilities for the childless adult category, which they had expanded back in '94, and that would be the big plan. And so by August of 2005, people started getting letters in the mail saying like, hey, your Medicaid coverage has been terminated. Thank you for coming, kind of thing. And obviously people couldn't enroll in some way. So that came out to have about 170 to 230,000 people. There's different estimates of Tennessee residents who would drop from TennCare given this reform. The governor estimated that it was going to be 430,000 initially, so they thought it was going to be worse. They're proposed to be that because there was a lot of pushback because this included children. And as you may know, in the context, sometimes when you touch with the children, there's a lot of more sensitivity. And actually, there was a lot of legal battles. So the government got sued based on what they were going to do and stuff. And that's why they decided to do just kind of like childless adults. This other paper has estimated that about 90% of the individuals who were dropped were childless adults, which is consistent with what we see here. Other surveys, you don't get that 90%, you get like less so. So take that with a grain of salt. What does this mean? About 4 to 6% of the non-elderly population, I'm not talking about the eligible population, but the non-elderly adult population of Tennessee residents lost coverage because of this reform. So it's non-trivial, I think, amount of people who did it. We can talk about how much money did it save. When you talk about how much money the government saved, it's a little bit of a different accounting exercise. We'll give you different, flavors of things because for every Medicaid dollar that you don't use, you actually lose money from the federal government. And so whether you want to include that or not, the estimates of how much money you're saving changes. Yeah?
Not elderly, adult, 65 and over, maybe elderly still?
Yeah, Medicare, right.
Okay.
So this is think of 19 to 64.
Adults, adults, so are we going to adults starting at the age of 18 and going on?
That's right. Yeah. So childless adults, thank you for that question. To clarify, is people who don't claim a dependent and are between 18 and 64. And just to be clear about not claiming a dependent that is under 18. So I could have a kid that is 24. I'm considered a childless adult. I could also have a kid that I don't claim as a dependent because let's say I'm divorced. I'm also a childless adult. Right? So it doesn't technically mean not having children. It just means you are considered childless adult under the view of the law or taxes maybe. I don't know if it's the law actually. Anyways, so here I wanted to show you a graph of what I kind of just talked about with data. So Tennessee kept record of the number of people enrolled in TennCare annually before 2005. So that's where you see kind of like dots up and down and just dots. And starting in 2005, because they knew this was coming, they started doing monthly counts. And so the data from starting in 2005, this is administrative data, comes really nice and finely. And what you can see is August of 2005, boom, big drop starts that ends in about, I think, May of 2006. So it takes about 8 months and then kind of stabilize stuff. So this is kind of the cleanest thing that you can see. There's no manipulation here with the data. It's just raw data of that drop that happened. So, who do we think are the people who were dropped? So these are some summary statistics from a paper by Godfrey Gross and Rodrigo. And they estimate that about 90% of people were people that are childless adults, right, as the definition that I just talked about. Most of these people, so about, I'm adding that 40 plus that 30, it's about 70% of people were 35 to 64. So I don't know if you want to consider that older population. I'm 36 myself. That's, I feel young still, so, whatever. 60% of them are females, 75% are white, and then about 80, a little bit more than 80% of them are high school graduate or less levels of education. So, none of this may be as surprising in terms of lower income is usually correlated with lower education, achievement, and so on. So what you want to think about this population is older, childless adults, and that have high school degree or less type of education. And then we compare them to other reforms like the ACA, Massachusetts Health Reform, and OHE's the Oregon Health Insurance Experiment. It really is the most similar to the ACA Medicaid expansions. And that's not surprising because the main expansions that happened were categorical, i.e. childless adults were become eligible. And so that's why it kind of looks very similar to those ACA Medicaid expansions. So back when we were doing this research, this also felt really relevant because this is a time where people were trying to repeal the Affordable Care Act and therefore the Medicaid expansions, and understanding the implications for that population is important. All right, so this provides this reform that we're going to use to understand the causal effects. So we actually want to know the causal effects. And really what we're going to do is two kinds of designs. We're going to compare what happened in Tennessee in kind of like the aggregate before and after 2005 to what happened to other southern states that did not experience this disenrollment before and after 2005. And that's how we're going to gain a lot of our estimates. Another set of design is we're going to compare counties in which a lot of people got disenrolled versus counties with a lot less people got disenrolled and seeing what happens to those counties. And presumably, let's say if it affects financial effects, those counties that got more people disenrolled on average are going to do worse in financial than the people who got less disenrolled. So these are all part of what we like to call a difference in difference strategy. This is just kind of like the regression or the model that we use to estimate that, where again, the main assumption is that the trends would have been the same. And I just want to show the intuition of this really quickly here. So this is survey data, and you can see health insurance rates in Tennessee, which is the blue dots, versus all the other southern states on average, right? You can see Tennessee had higher. That makes sense because they had more generous public health insurance plans. And what you see there is that before 2005, once you account for a lot of the data noise in some way, those two things are moving in very similar ways. But then after 2005, there's convergence. And that's really what we're going to use, that intuition to say like, okay, look, if Tennessee wouldn't have had this reform, they would have kept the same trend that they had before, which is similar to what the other southern states trend is. And that's kind of like what we're using for identifying. And then this is the model for the dose response, which is that county identification strategy. So just to build some intuition, different counties had different rates of how many percentage of people were dropped, right? So in the red counties, it's about 9 to 13% or 14%. In the yellow counties, about 1 to 4%. You can see variation in this way too, right? But then really the identification strategy here is we're going to compare those counties, let's say in the orange line, which are like, let's say 35% of their population was enrolled in TennCare, and they're going to see a much bigger drop than the counties that had only, let's say, I don't know, 17% of their population in TennCare, and they're going to see a smaller drop. And so we're going to compare those two types of counties, controlling for things like income and so on, or things that we may want to control for to get that inference. All right, so what has been explored under the umbrella of this reform? So a bunch of different outcomes, which is great, and this is kind of like the literature that has been contributed for the past few years. And what I show you is the following. First, I'm going to show you the insurance effect. So people may lose Medicaid, but then does that mean that they lose insurance, period? Or do they find other ways to get insurance? The financial repercussions, we're going to talk about health. And then hopefully we get to employment and crime as well. All right. So do people actually lose health insurance, or do they replace it with something else? People can be really creative, so let's see what happens. So we find that there's a 32% reduction in people reporting having Medicaid in Tennessee, period, right, relative to other southern states. So about a third, which is pretty sizable. These results are consistent across many different surveys that we've tested this data on, and other authors have tested this on. Out of the people who in surveys, they report losing health insurance, so not out of everyone, just the people who report I've lost health insurance recently, about 93 to 98% of them reported loss in Medicaid, right? Which is exactly what we think this is capturing, this loss of Medicaid in Tennessee, right? Overall, we estimate that about 60 to 69, depends on the numbers you want to use, of individuals who lost Medicaid remained uninsured up to 2009, so about 4 years after the reform, remained uninsured. So the reason why we stopped, by the way, in 2009, a lot of these papers is because the recession starts coming in at that time, and even though we can account for those effects, we think it's cleaner if we just see it before the recession kicks in and complicates things. What does it also mean? So if you think this is bad news, I mean, if you want to see something of good news, is that about 40 to 30% of individuals actually find other ways of being insured, whether that's private health insurance or through their employers or through Medicare, whatever that is. Other people actually, a substantial amount of people, I would say, found other ways of having insurance. But obviously, the majority of them remained uninsured. So that's like a big kind of like important question in like what happened in this reform. If we look at each category of like where did people go, we lose a lot of precision, and so it's a lot of very noisy. It seems to be that some people went to private, but it's a little bit unclear. It's not very consistent across surveys, so I think it's hard for us to determine that, at least with the survey data that we have. And unfortunately, there's not a lot of administrative data that has it, because once you're off of Medicaid, then you're not appearing in that data anymore. So it's hard for us to know where did people actually go. This is just a graph that maybe I'll show you a couple of times. Now, the idea of this graph, so I just want to talk about it. This is what we call an event study. So long story short, this is the difference between, let's see if I can go back. This is each point is the difference between Tennessee and the other southern states at each kind of like point. So at each point is the difference here, accounting for different stuff. And what we want to see, as we see in this graph, is that the difference is pretty much zero before 2005, so they're evolving in a very similar way. But then once 2005 hits, we see divergence. And this is all coming from Tennessee diverging from that trend. And in this case, this is health insurance rate, which you see goes down. And maybe in 2009 starts getting back up. And again, we can extend that, but we don't know after 2009 what is recession and what is not. Okay, so that's insurance effects. Let's then go see what happens to financial effects. And I'm putting financial effects first because I want to make a point that hopefully it's clear to everyone, but sometimes it's not, that the probably most important outcome for like if a health insurance is working or not is its financial effects, right? At the end of the day, health insurance is a tool to mitigate financial risk. In the same way that I would expect my car insurance to run my car better, or I would expect my home health insurance to make my home run better, I really should not expect my health insurance to like have better health for me. Right? And I think we sometimes get, lost in this idea of like, does health insurance affect health, yes or no? And like, if it does, great, that's a cherry on top. But really the question is, does it mitigate financial risk? Because that's really what it's built for doing. So sometimes, I think we get a little bit confused in that narrative, and I just want to make sure that like, the main importance of health insurance is mitigating financial risk. So let's see if it's doing that or not. So what happens to people's finances? So for this, we use data on credit reports. So anyone who has a credit score, we have the data for all these individuals across time. Unfortunately, we don't have data if they had insurance or not. So a lot of the stuff we had to do is on aggregates. This is where you use that county identification format. So what do we find? Overall, big headline result, losing health insurance does expose individuals to greater financial risk. So it's exactly what you expect. This hopefully is not a surprise to a lot of people. What do we actually find? We find about decreases in your credit score on average, this is all on average, of about 47 points. What does that mean? Well, credit scores actually don't move very often. So that means like losing progress in your credit for about 5 to 10 years, depending on your person. So a pretty sizable effect in your credit. We also see people increasing their delinquent debt. Delinquent debt is a debt that you haven't paid 90 days after it is due. Right, so if your payment due is at the end of October, think 90 days that, and you still have that balance. And we think that's about $1,000 on average per person I think this is per year, not per quarter. And then we obviously see, well, not obviously, but we do see some small effects on bankruptcy. Bankruptcy is a very like extreme outcome, right? It's almost like mortality is like something, there's very little after bankruptcy. So, but we do see some increases of 1 to 2%, depending which estimate you use. So that is like tangible, bad financial repercussions, right? The people who were affected the worst were the people that started with the lowest credit score. So definitely the people who have like least financial access to other stuff are the ones who are getting the most affected. And so then if we are thinking about like, well, okay, if people have to pay their medical bills, and because like the whole way we think this is working is, you don't have insurance, you have a chronic condition, you end up in the hospital, you end up in the ED, you get a big bill, you have to pay it, and that creates a lot of this stuff. So what do we think is happening? With the data, we can see that a lot of their debt is going into the credit cards. We actually don't know with this data if they're paying the medical bill with the credit card and then they just keep that balance in the credit card past due, or is it that they are paying their medical bill, let's say cash, and then they're not paying their credit card for other stuff. Like we can distinguish that, but essentially what we see is just a lot of this stuff is getting on the credit card, which if you have ever had debt in your credit card, it's pretty dangerous because the interest rates are really high, and that could lead to a lot of different stuff. Then we see delay in payments of your car loan. So that's another way that people are mitigating this financial risk. I'm not going to pay my car payments. But we don't see any delays in paying your mortgage. So if you do own a mortgage, then we don't see any changes in that. So people are prioritizing putting stuff in the credit card, not paying the car, but I'm going to keep paying the mortgage. Now, the caveat is, what is the fraction of people who are eligible for Medicaid who has mortgages? And so take that with a grain of salt. Another set of co-authors did find evidence of an increase in rate of evictions. So we think most people rent. If there's a financial hardship, maybe they're delaying their paying rents. And we actually don't know if they are delaying to pay rents, but we do see an increase in filing for eviction. So presumably that is rent delay. And they see about a 25% increase in evictions in Tennessee relative to other southern states. So pretty sizable one.